Hello, my name is Diane Scardino, and I am a Vice President with Texas Children's Health Plan. I am super excited to be here welcoming all of you today, and also representing my organization, which is a member organization of the Baker Institute. So my guess is many of you have heard about Texas Children's, but for those of you that haven't, let me give you a little bit of information on our organization as we get started, and then let me welcome our speaker. So Texas Children's is all about creating a healthier community for women and for children. I said women because that one's kind of new. We usually lead with children. Our care delivery system is 3 hospital campuses, multiple campuses for subspecialty care, and over 50 primary care providers around the greater Houston and now Austin area. We have over 4 million patient encounters in any given year, and actually, we also have the awards that really support all the things that you would think we would want to support. U.S. News and World Report, Best Doctors in collaboration with Baylor College of Medicine, magnet recognition, and all of these are really important because we would consider ourselves not only an academic institution, but even more importantly, a learning organization. A learning organization is one of those places that is always looking toward the future and figuring out what is it that we need to do better, be it customer satisfaction or, more importantly, clinical outcomes. So that's all important, and I've been part of that component of Texas Children's for many years, but for the last 2.5 years, I've been part of a different part of our organization, and that's Texas Children's Health Plan. And it's actually through that lens that I was most interested in today's luncheon, because that lens makes me really start looking at topics such as coverage and access from a really different vantage point than what I looked at when I really supported the care delivery system. Not that it's not important there as well. And so when I think about this, I know that whether you're here representing an insurance company, public policy, whether you're here as an individual or maybe you're part of the care delivery system, the topic of the future becomes really important. And so I'd like to consider all of us here today kind of our own little learning collaborative or learning institution. And so what do we do when we want to be one of those types of organizations? You really start to leverage experts, don't you? So let me talk about an expert today, which is why you're all here. Dr. Vivian Ho is the James Baker III Institute Chair in Health Economics, Director of the Center for Health and Biosciences, a professor in the Department of Economics at Rice University, and also a professor in the Department of Medicine with Baylor College of Medicine. She has a vast amount of research, and that research has examined the effects of economic incentives and regulations on quality and costs of healthcare. And many of you have heard her speak on topics in the past, and I'm sure that cost and quality are going to come into the conversation today as well. Her research has been widely published in economics, medical, and health services research journals, and has been funded by the National Institute of Health, the Agency for Healthcare Research and Quality, and the American Cancer Society. She has also served on many boards. Some in particular is the Board of Scientific Counselors for the National Center of Health Statistics, as well as on the NIH Health Services, Outcomes, and Delivery Study section. She is also a founding board member of the American Society for Health Economists and a board member of Community Health Choice, which is another significant health plan in our community. She received her undergrad in economics from Harvard University, a graduate diploma in economics from the Australian National University, and her doctorate in economics from Stanford University. Please help me in welcoming your expert for today's topic.
Thanks so much, Diane, for that introduction. All right, so what I'm going to do first off is ask you to pull out your cell phones because we're going to do a little bit of audience participation today, and so hopefully you can find some room on your table to use your cell phone if you have it. You want to go to whatever your web browser is and just type in Socrative Student Login. That'll get you to the Socrative website. And then when you are up on that website, you will actually see something that hopefully looks like this, and you type in CHB 2020. So I'm sure that will take you a while to do that. So while I'm doing that, let me tell you, some of you know my own personal health challenges this year, and so let me fill you in on some of you who are not aware of that. And so I started off, I had some spare time in mid-January, so I actually went to a Medi-Spa, and I thought about getting a laser treatment to lighten up a couple of dark spots on my face. And the woman doing the procedure, actually I was lucky, she was a nurse who had just come to Houston from Dallas, and she had worked in plastic surgery at Texas Southwestern. She felt down here and she said, hey, there's a little bit of a lump down here and you might want to go get it checked out. So I was like, yeah, okay, I'll go and do that. Mara Short, who works in the Center for Health and Biosciences, had a cyst on her neck about 10 years ago. And I thought, oh, it's just one of those. So anyways, we sort of went through GP, ultrasound, and unfortunately, I found out January 31st that a CAT scan came back, and it looked pretty likely that this was a cancerous tumor in my parotid, which is a salivary gland. And I was extremely lucky. We are near Texas, MD Anderson Cancer Center, and fortunately they operated on me on February 14th, and they removed the tumor. It was cancerous, and they're pretty sure they got everything out. They took out 25 lymph nodes along the way, but the fortunate thing is that I don't have to have radiation therapy or cancer. They think they got it all, so thank goodness for that. And I would like to thank so many people. This was major cancer surgery. It was eight hours. It took 3 surgeons, a head and neck surgeon, an ear surgeon, and a plastic surgeon. And it was tough, and I could not have gone through it with, there are friends throughout the audience, and you know who you are. And thank goodness for your support. Thank goodness for my staff and for the other personnel at the Baker Institute who gave me all the room and all the support and backup so we could just keep running smoothly. And so I really hope some of you have been through this before, I know, in some other health challenge. You get to a point where you're wondering whether you're scared and you don't know whether you're going to survive or not. And you're sitting there and you're saying, maybe to your God or maybe just to yourself, I'm not ready to go yet. And then you say, I'm not ready to go yet because, and of course the first thing that comes is your family. That, there are things that I still was planning to do with my family and want to be with them. Now you're going to think I'm a real nerd, but the other thing was I'm not ready to go yet because healthcare costs are just too high and I'm not done trying to deal with that. So for people who can understand that, the people who support the health policy, the members of the Health Policy Forum, thank you so much. Thank you for helping us to continue on this because without your support, we couldn't continue with that particular battle, and I plan to be hanging around here for a long time to work on that. So, with that being said, I think hopefully you managed to all find the website, and we can move on right here. So I'm going to we're going to do 4 different questions. I'm going to give you just a tiny bit of background on where we stand right now in terms of expenditures and insurance. I'm going to talk about Medicare-For-All, Medicare for America, which you may not have heard of yet, but we'll talk about that, other health insurance proposals, and then just a tiny bit about healthcare issues. I want to save time for questions because I'm sure you're going to have questions about other things that are come up that I don't have time to cover, and I like to leave lots of discussion for Q&A because this is always an intelligent audience that has thoughtful questions. So question number 1, in choosing the next president, the most important policy issue to me is, and so I'm going to switch over here. Oh, you are all in. So go ahead and this should be on your smartphone. And we are not recording any of this. I will not know who said what. So don't worry about that. Maybe Facebook will figure out a way to collect all this, but disclaimer here, not me. Okay, well, we don't really have everyone, but I'm going to say, how did we do? Let's find out what you think. I have no idea what you're going to think, and I'm really curious to find out as well. Well, okay, this is a talk on healthcare. And you can see a third of you said that's your most important issue, but I think it's interesting that you have quite a good distribution across all the different topics. So that's where you all stand, all right, in terms of what your most important health issue is. Issue for the next election. Okay. Now, this is a picture of 22 of the candidates. There's one missing. Don't ask me who it is. I don't know all of them. I know many of them, and you know the front runners, of course. We've got Bernie up here, and Joe Biden, Elizabeth Warren, Kamala Harris, Cory Booker, Amy Klobuchar, and Kirsten Gillibrand. Arguably, sort of why is she up here and why isn't he up there? Of course, we know Beto and Julian Castro. And this guy, you recognize him? Okay, you can find YouTube videos on how to pronounce his name, which I understand is Buttigieg. So hopefully I got that right. And many others out there, and you may have your favorites. I could not put them all on a poll, otherwise we'd be here and spend the entire lunchtime choosing all these people. But my next question is, my preferred presidential candidate for 2020 is, okay, so given the list, do the best you can. And I'm going to go over here to next. Oh, I forgot to put an other. I apologize for that. So I chose the names. There are two Republican candidates up there. William Weld is trying to run against Donald Trump. And then I've got mostly the front runners in the Democratic polls, but I also added on the two Texans because I thought they might be more popular here. So. And we'll have a survey about this afterwards, so feel free to complain on the Survey Monkey response if you don't like what I've done. Okay, let's see. Wow, fascinating. Okay, I think this is fascinating. So there you go in terms of what we have in terms of our preferred candidates in the audience. And yeah, it's sort of, I want to compare this to the poll numbers because of course it's not going to be exactly, but I'll have to find a Texas poll and see how we're doing on that. Okay, so. I must say, I thought, gee, I'm sick, and normally we have this talk at the start of the summer. Maybe I should postpone until later in the fall when I'm feeling better. But then, oh gosh, what happens if there are 30 candidates by then? It's like, it would make the talk even harder. So I'm glad I'm doing it right now. Okay, so here we are in terms of what does the country look like for healthcare expenditures. This blue line here is showing you the tremendous growth that we've had in health expenditures over the last several decades. And you can see it's just steadily rising upwards, although this is the growth rate here, all right? And you can see that, yes, we've had a decrease in growth rates of healthcare expenditures over time. The federal government predicts growth rate expenditures. Notice here, we're somewhere between around 5% in terms of growth rate. So we've had an uptick here when the Affordable Care Act kicked in and covered more people with health care insurance. So it's no surprise if you have more people with health care, the Medicaid expansion, you're going to have more health care expenditures. The disconcerting thing is that this number is well above rates of growth of the economy. all right? And so healthcare continues to take up a higher proportion of our expenditures, and so this is a concern. And here we are in terms of the percentage of people who are insured in this country. So we have here, this was sort of record high percentage of adults uninsured before the Affordable Care Act kicked in, and then once the marketplace opened and it actually started functioning well, we got down to some very good rates, 10.9% here in percent uninsured. Trump was elected. He attempted to repeal and replace the ACA. He was not successful. However, he has been quite effective in making it harder for people to get marketplace insurance by not funding navigators as much as should be to educate those who need health insurance on how to sign up for it. He's also removed sort of cost-sharing provisions that give subsidies to health insurance companies to cover those who are low income. That's been worked around a little bit, but then lately he's also been effective in terms of eliminating the mandate to buy health insurance. And some people said, oh, if I don't have to buy insurance because I'm not going to get penalized, they have dropped it. And so now we are up to 13.7% of adults uninsured, and that was also at a time when you see national health expenditures are rising. Okay, so that's kind of a concern. All right, so we're in the 116th Congress. We started that in January, and Democrats have been introducing bills. There's Medicare-For-All. We're going to talk a lot about that. There's also an option we'll talk about with national health insurance and opt-out if you're covered out by an employer. You'll see that. Some people want a public option in the marketplace. There's the notion that Hillary Clinton was trying to promote when she was running for president, the Medicare buy-in if you're over age 50, and then there's also the possibility of Medicaid buy-in through the ACA marketplace. Okay, so I'm gonna mostly talk about Medicare-For-All. So if you check out the Washington Post every once in a while, they have, you can just Google Washington Post Medicare-For-All, and this comes up. They update it every once in a while. You probably, I'd be most impressed if you could read all the lettering on that slide, but it sort of splits the different candidates, and I'm going to show you a lot of these different slides and where the candidates stand on some of this. But you see, a fair number are saying some version of Medicare-For-All. All right. There are also those who say they'd like something else. Here's Beto down here, and we'll talk about him in a few minutes. And Joe Biden, they're saying, is actually unclear, no response on this. He may be waiting to see where the public sentiment is lying on this issue. Okay, so this is how the current insurance system works. Super simple. Of course, it's much more complicated than that. But basically, when you're most people who have, most people who are patients pay a premium of some sort to an insurance company, and the insurance company then pays the healthcare provider, the hospital, the physician, or physical therapist, whoever you're seeing, for their health care, and you are often responsible for a copay or a deductible. Okay. This is what a single-payer Medicare-For-All means. We can actually get rid of an entire line. Makes the diagram easier. So there is no insurance company left. There's the government. Patients pay taxes, and then the government pays the providers for their treatment. But there's also a modified type of plan, which is actually similar. You'll see something like this in Canada, where you still have the government, and you're paying taxes, and the government pays the providers for their treatment. But you can also have elective coverage. And so then you'll have insurers, but they can only insure supplementary or complementary services, and they could pay your providers. Okay, so there's something like that for drugs in Canada, kind of, sort of, but you could think of, well, one could have that type of system if you had, say, dental procedures or optometry or things like that, and if you don't want to have that covered in your national health insurance plan. Okay, So you've seen that, the simple diagram. Now we're on to question 3. I have employer-provided or marketplace health insurance, and I would be willing to give it up if the United States provided health care to all legal residents, and I had the option to personally purchase coverage for access to providers who chose not to participate in Medicare-For-All. Don't feel like you have to respond to this if you don't have employer-provided insurance or marketplace health insurance. Okay? Okay. Ooh. All right, let's see how you responded. 68% would not be willing to give up their insurance. I would not either. Thank you very much, Sue, over in Human Resources at Rice, for giving my insurance with MD Anderson included as a provider.
It's the other way. Would say yes.
Oh, would. I'm wrong. Wow. Okay, this is really interesting, and I made up this question, so I don't know if I can find a national poll to compare it to. Okay, thank you for that. I apologize. So moving right along here. Okay, so this is where the candidates stand in terms of what should happen to private insurance. Okay, so Bernie, just get rid of it. You've seen that in the paper. There are some who say, for now you can have it, which I don't know. I don't know if that's a waffle or not. And then you see the majority of them actually are saying we don't need to get rid of it. And then there's this unclear no response group over here on the side. Okay, so here's another sort of, so if you said yes to the last one, you'll probably say yes to this one, and we get some of the no's to switch over. Do you support partially expanding Medicare by allowing people ages 50 to 64 to buy into Medicare? Okay, and so again, this is what Hillary Clinton was trying to propose. And most of those say yes, and then there are those who, over here, who are saying, that it's unclear, no response. And this I find a little bit surprising that you're going to say unclear, no response, particularly because there is at least one face over on this side who actually said that they were in favor of Bernie Sanders' Medicare-For-All. So that is kind of not making sense to me. Okay, do you support creating a public option to expand health care, such as allowing people to buy into a state Medicaid program regardless of income? And then everyone says yes. And maybe Julian's campaign group will see this, and there'll be something that will be added to his webpage soon. Okay, so let me spend time talking about Medicare-For-All, and I'm talking about Sanders' characterization because he really was the man who came up with this idea. This is, again, single federal program, comprehensive benefit for all U.S. residents. And his proposal really does, it talks about covering everything, dental, vision, you name it, and almost no copays or deductibles. Okay, tax finance, so you do not pay a premium. And there's very limited cost sharing in terms of copays or deductibles, as I mentioned. So you're getting rid of everything. You get rid of private insurance, you get rid of Medicaid, Medicare becomes part of this, and children's health insurance program as well. Just one plan, all right? And we'll talk about this. You know, it's sort of, when I say payment of hospitals and doctors and Medicare at Medicare rates, it's a little bit more complicated than that. But in the bill, it sort of says, look, you know, Secretary for Health and Human Services is going to determine the rates subject to that part of the act that governs Medicare rates. All right, so let me show you the details of a prediction of how much Senator Sanders' program would cost. And this was done by Charles Blehaus for the Mercatus Center. And you may recall it actually got a lot of press when it came out last summer. So what he's saying is, we project healthcare spending in 2022 to be $3.859 trillion. Now, if you give Medicare for all, you're suddenly covering everybody, and you're lowering the copays. This is very generous health insurance. And so when you give people health insurance, they buy more health care. That's just known, and you know, there are hundreds of studies that show that. So his estimate of the increase in health care is $435 billion. All right, now, the Sanders bill does not exactly say what the rates for providers would be, and so Blehaus decided to be generous. He said, I'll just assume that all hospitals and physicians are going to get paid what they're currently getting paid under Medicare, okay? And that's generous because, as you'll see in a minute, private health insurers reimburse providers at a much higher level, and they're much more generous. Okay, so provider payment cuts of $384 billion. There's also legislation that cuts spending on drugs through one of the major things is negotiating. The government would negotiate directly with drug companies for the price of drugs. And so he says, well, okay, so you'd reduce healthcare spending to $3.849 trillion. Okay. Currently projected national health expenditures for 2022 are $4.562 trillion. He's saying, okay, we saved $10 billion with his program. He also says, look, we're going to have administrative cost savings. And yeah, that's true, because suddenly you're not going to have your private health insurers going back and forth and fighting with the providers over what they're going to pay them. So best estimates suggest savings of $83 billion. So expenditures under the Medicare-For-All would be $4.469 trillion. Now, if you look at the federal share of national health expenditures, projected in 2022, it's $4.244 trillion. You count for the amount that would stay in the legislation in terms of what you're collecting from taxpayers for health care through the Medicare program, you know, your payroll tax and state contributions to the Medicaid program, things like that. So you take off the government's portion they're already paying, and the net addition of Medicare for All to the government budget in 2022 is $2.535 trillion, okay? Current GDP for the US is just a little bit above $20 trillion. So, CBO, Congressional Budget Office, and all the other ones do these predictions in terms of 10-year impact. And so, Blehaus, and you know, there's changes over time for various different reasons, predicted changes. So for the next 10 years, Blehaus comes up with a number of $32.6 trillion, okay, over 10 years. If you want to think about it, I looked up, I don't have it on a slide, but Congressional Budget Office for that 10-year time period estimates outlays will be about $57 trillion. Total federal outlays for everything, including Medicare, including Social Security, defense spending, and education. So that tells you over that 10-year period the relative size of this magnitude. And you're saying, okay, if you really like to follow these things, Mercatus Center is libertarian, for crying out loud. How can they be unbiased in this particular statement? Well, you go to the Urban Institute, they did predictions of the previous version of Medicare for All. And the Urban Institute, which is definitely considered a liberal think tank, estimated $32 trillion. The Center for Health and Economy which Playhouse cites, I'm not sure who they are, but they came up with an estimate of $27.3 trillion. The lowest estimate was Ken Thorpe, who worked for President Clinton. He's an economist at Emory. His is the lowest estimate. It still stands at $24.7 trillion. Okay, so what about, sort of other issues? What about the taxes proposed by Sanders to cover the costs? That's one of the things that came to my mind. I'm just going to give you two things that I thought of immediately as I read this. And then, would doctors and hospitals be willing to serve all patients at Medicare rates? Is that really going to work? Okay, so if you do a little bit more web searching, you'll find Sanders' proposals for financing Medicare-For-All. And the scary thing is, in the document that I found said, this is a list, but it's not necessarily inclusive. So there could be more, all right? So here's one, a 7.5% tax on employers. Okay, the first $2 million exempt for small businesses. Okay, so you sort of think, well, employers don't have to pay for health insurance for their workers anymore, so it's fair enough to have this tax on them, and maybe it actually would be a savings. It turns out, if you look at the latest figures, employers spend, I think it's 8.3% of wages and salaries on the employer-provided premium for health insurance, okay? So this is about a wash. It's not as if workers would suddenly get higher wages if you move to Medicare-For-All. Not only that, he wants a 4.4% tax on employees, okay? If you look at individual coverage, if a worker is just buying coverage for themselves, that cost is currently for the average worker about 2.2%. So the worker would have to pay more, and they're still paying their payroll tax, their Medicare payroll tax. That doesn't go away. That's still in the numbers. Fee paid by large financial institutions. You make the estate tax more progressive. You make the income tax more progressive. A 70% top rate. Okay, current top rate, what is like 40-something%? Establish a tax on extreme wealth. And repeal corporate accounting gimmicks. So that's in the document. And again, we still don't know if this would be enough money, all right? The Congressional Budget Office has not done a calculation of whether this would be budget neutral. But to me, I find these numbers scary. This is a lot of money, and I don't think we, of course, we always have enough money to spend for something, but the question is enough money to get it through our political system, and the amount of lobbying that would go. I guarantee you there are going to be plenty of physicians and hospitals and private insurance companies lining up on the other side to argue the other side of the story. And if you don't believe that, you look, think of the battle we went through on Obamacare, and this would be 10 times worse. And then all sorts of leakage happens because everyone was brought to the table. Doctors and hospitals and everyone else got their say. The Obama administration said, look, we want you, we want to have these higher expenditures. We're going to make you sacrifice, but there are going to be more people who are insured who are going to buy your products, so you'll be better off. Okay, so they did that to the medical device companies. They agreed to a 2% tax or something like that on their particular medical devices, and now you see them fighting and screaming, and they're managing successfully politically to get that tax postponed, and they're still postponing it. They're still not paying it. So that's the kind of thing you have to watch out for politically. All right, so the other thing I said, do you really expect physicians and hospitals to accept Medicare for all of the care provided? This is a graph constructed by some Congressional Budget Office economists, and they took 20 different common and costly procedures that you would find in both the Medicare population and the under 65 population. And again, I know you can't see these. You'll be able to email and ask for the slides later, but there's things, patient visits here, cardiac catheterization, hysterectomy, lithotripsy, PET scans, all the way up here is an MRI scan. And let's just focus here. These are the red dots. okay? These red dots are the ratio of the average price that private insurers receive for these services relative to the Medicare payment. And right here, this line is 150%, okay? So there's 21 services, and for 15 of these services, the price is 50% higher when it's paid for for a privately insured patient than for a Medicare patient, right? And so, yes, people talk about, I would like physicians and hospitals to take a sacrifice and take a pay cut. I just don't know anybody who's willing to take a 50% pay cut. That's just not realistic. And just wait and see the type of lobbying and advertising that would result if someone actually tried to propose something like this. Okay, so that's one way to look at it. Let me show you another way. So there's a consulting company called Navigant that I learned about from being on the board of Community Health Choice. They do a lot of really good number crunching and a lot of big data simulation. And so what they said is, let's create a hypothetical medium-sized healthcare system. We'll call it Excelsior, so this is not a real one, but they plugged in all the characteristics you would for a large healthcare system. So mostly hospital care in here. And they said, right now, the status quo, the average, the operating margin for this health system, and let's say it's healthy, is 2.3%. So this is fairly representative. This is what you expect for a lot of health systems right now. And they did various simulations, and I'll show you all of them eventually. But these are the profit margins if this hospital was moved to payments, Medicare rates under Medicare-For-All. Okay, so this is one if they're paid Medicare rates, and the profit margin is minus 22%. All right, even if you said we'll pay these hospitals 20% of what Medicare pays right here, you know, the margin is 14%, minus 14. All right. Maybe a hospital can operate like this for 1 year, but it's certainly not going to last very long. All right. And this is your representative system in an urban area with plenty of customers and plenty of, you know, sort of what you would think is plenty of income. Think about what we have in terms of rural hospitals. Many of them are struggling even to make a positive profit margin right now. Okay? So this is just Medicare rates for everyone is not feasible. And this is the problem when you propose legislation to voters where no one has gone through the calculations and said, well, this is what could happen. And this is what I'm very concerned about this campaign, that we are talking about things that are just not even feasible for our current healthcare system. All right, and so as I mentioned, the CBO does all sorts of great predictions. Someone asked them to come up with some sort of discussion. Well, suppose we went to single payer because so many people are talking about it. Can you write us a document that showed us, you know, what we have to think about? And so you can pull up this document, and this is the front cover, and it shows you all the different types of things that have to be discussed. Administration, eligibility, enrollment, goes on and on. When I first found this document, I thought, oh, this is great. I'll be able to pull this out, and this will be, you know, my presentation. But see the headlines on this. The highly anticipated analysis, which is this one, by the CBO, released yesterday by a nonpartisan organization on Medicare-For-All, told us this much: transitioning the United States to such a single-payer healthcare system would be messy, very messy. Okay, those are the experts. This is what they said. And I'll show you. Okay, so I showed you the cover. This is what's inside the document. All right? And so they even fleshed out, these are all the different types of things that would have to be argued over and decided if you wanted to move to a single payer system. And, you know, I talked a little bit about cost and financing, the taxes that you would need, okay? How would the system contain healthcare costs? So I didn't even talk about that. Payment rates, how would the system pay providers and set provider rate payment rates? Okay, so this is all very scary. Actually, I did read the document and my eyes just glossed over and I thought, oh, there's no way I'm gonna present this to you because you'd all fall asleep, which is I had a very good nap after trying to get through this. Okay, so that being said, let's move on and sort of see what we can find is there anything else promising? So Medicare for America, this is a bill that was introduced, it's in small print, by Representative Rosa DeLauro from Connecticut and Representative Jan Schakowsky in Illinois. So that's out there, it's a bill. It's what Beto is in favor of. So first what you do is you automatically enroll everyone, newborn, uninsured, Medicaid, and then anyone in the ACA marketplace goes into this plan. People can keep their private health insurance if the employer pays 80% of an employee's health care costs. Now, that's actually not most healthcare plans. You look on the average, it's actually patients are paying 30% out of pocket. Okay, so we're getting strict on that. If your employees don't have coverage, the employer would have to pay part of that cost to the government, okay? And employees also have the choice. They don't have to take the employer's health insurance. If they want, they could jump into the public program. Okay, they want to adjust premiums according to the income of the particular resident. Low-income persons pay no premium. There's out-of-pocket, there's out-of-pocket premiums based on income, $3,500. Out-of-pocket costs capped at $3,500 for individuals and $5,000 for a family. Okay, so that's lower than what we have now. You see actually $6,000 deductibles commonly in marketplace plans. And then, honestly, this is in legislation that you can look up for yourself. It says, a rate schedule to reimburse providers will pay them at a level to ensure adequate access to providers. I looked at that and my jaw just dropped. I thought, are you kidding me? You know, this is a proposal. So what bothers me is that these candidates are not consulting with any types of economists to figure out what sort of payments do you need. I don't think in many cases we actually have enough sufficient rates that all patients have access to coverage to providers now, okay? We've got plenty of examples of people with private health insurance who can't get access to a provider in certain parts of the country. So this question definitely needs much more careful thought. Okay, so how do you finance this? 5% tax on people with incomes over $500,000, excise taxes on alcohol, tobacco, and sugary beverages, eliminate some current tax cuts, raise the Medicare payroll tax so it would go up from its 2.9% current level, raise the net investment income tax rate, and then you require the states to pay the amount equivalent to what they're currently paying in Medicaid costs, and certainly you would need to do that. So again, it's just sort of a lot of smoke and mirrors and a lot of hand waving in terms of how to pay for these things. It probably is not enough to cover the cost of this. So, final question. Here we are. I am willing to pay higher taxes in order to obtain health insurance coverage for more Americans. And given what you said to the last question, you sure as heck better be consistent. So I'm guessing, I'm guessing what you're going to say on this one. Okay, how do we do? Yeah, okay. You are, remarkably consistent. Okay, 68%. And I will not ask you how much you'd be willing to pay. But there you go. Okay, then I could ask, how many of you making over $500,000 a year? Okay, so that's that particular approach. Now, this is something that was debated when the Affordable Care Act was being rolled out. There were many people who wanted a public option, and this I find fascinating in terms of the calculations. So you say that marketplace enrollees could continue with their current marketplace plans. If you like what you have, you can stay in that. Employer-provided health insurance stays the same as it is. And here's what the CBO calculated prior to the legislation being passed. It actually said premiums would be 7% lower in the public versus the private plans. There would be sort of lower administrative costs, but also because they would set their reimbursements. They would say hospitals would be paid the same as Medicare, and physician reimbursement would be 5% higher than Medicare. And so the reason why they think this is a little bit more feasible is because it applies to a much smaller share of the population. This is not talking about moving all patients to Medicare rates, but just a portion. Okay, but you'll see what are the cost implications for our simulated healthcare system. And then the government can negotiate directly with drug manufacturers on drug prices. So the CBO, did these calculations. It's actually estimated to reduce the federal deficit by $158 billion over 10 years, okay? This approach is estimated to be cost-saving, but the reason why a number of conservatives did not like the idea is because they are concerned that it leads to a larger role for public health insurance, which eventually moves us even closer to universal coverage, and these are many people who philosophically believe in a smaller role for government, not a larger role. So that's why it was not included as part of the Affordable Care Act. But they're saying, look, if you have lower premiums, that means less government spending. And then actually, you get more taxable wage income, because what happens is employers are actually spending less on health insurance coverage for some of their workers. Some of their workers go to the public plan, which means they're accepting more of their total compensation as a wage, and the wage is taxed, unlike health insurance is subject to a payroll tax. And so it makes government more money that way. They estimated a third of marketplace customers would actually choose the public option. Okay, so here we are back at our simulated healthcare system. And so what they think is for the public option, if you're paying just at Medicare rates, it would be the profit margin still declines to minus 6.3%. If you pay at 10% higher than Medicare, public option profit margin declines to minus 5.7%. Still a money loser, okay? So maybe in order to keep all our hospitals open under a proposal like this, they'd have to raise the Medicare rates even more, all right? And it would be interesting to see how much it would cost, but certainly it's not going to cost as much as a Medicare-For-All type of proposal. Okay, Medicare buy-in for people ages 50 or over. If you're over 50, you could choose from, stay in the ACO marketplace or employer-provided insurance, or you could have traditional Medicare or Medicare Advantage, okay? And there's, there would be all sorts of different characteristics depending on which plan you chose, okay? There's not much uniformity in those. And any provider who accepts traditional Medicare would be required to see these patients at Medicare rates, right? And, but there would be separate financing from the Medicare program, so they'd have their own trust funds, and so they don't want to scare current seniors into thinking, oh my gosh, if this happens, my Medicare program is going to go under, okay? So they would be different pockets of money. All right, so this proposal, if it's voluntary buy-in at age 50, the profit margin stays about the same, okay? And if you have this other scenario where there's buy-in with employer choice, and this means that, you're actually letting people have employer-provided health insurance go into this system. There's a way you could do this and say, oh, it's only for the marketplace. If you have employer-provided health insurance, you have to stick with that. And that's a significant drop, minus 5.1%. Okay, so even that, you may have to raise rates even more to get providers to be able to survive or agree to see patients. Okay, just a few more things, just to run by you real quickly before we have some time for questions and answers. Do you support giving the federal government the ability to negotiate drug prices for Medicare? Most of the candidates say yes. I don't know why you would say no response or unclear unless you have stock in drug companies. Their argument is the drug companies respond, well, this gives us less money to conduct our R&D if you have this, and I'm just sort of like, look, the latest treatment for a particular type of cancer drug is what, $2 million a year? So when you're charging those kinds of prices, I think you have to let the public come in and exercise some negotiating power. Okay, do you support having the federal government produce and sell generic drugs to lower drug prices? It's not going to be a vote deciding, decision on which candidate you're going to choose, but there's all sorts of reasons why you could say yes or no to this particular response. And do you support importing drugs from other countries? I can understand if people are on the fence about this because you're worried about how you're going to regulate the control. Perhaps you could do it for a small number of drugs. Perhaps you could do it for a small number of countries. We have plenty of people. I hear the anecdotes of people going to Canada to buy their drugs and going to France and buying their medications. And so I would tend to think that anything you would buy in those countries would be trustworthy. I don't think I'm a chump on that. And then do you believe all undocumented immigrants should be covered under a government-run health plan? Okay, so given the debates we're having about immigration, that's an important issue as well. Although, keep in mind that there are many different issues which are public health issues. I'm in favor of providing vaccinations to undocumented immigrants. Because it actually keeps the entire population well. So there are many cases in which you do want to do this because it keeps the entire community well off. Okay, so for just this portion, I'm ready for question and answers. I think we lack a clear vision on feasible healthcare reform under a Democratic administration. I'm a bit disappointed. I really don't want this to turn into a debate on Medicare-For-All versus not. We've got a troubled healthcare system. There are many things that we need to focus on, and I think the Medicare-For-All distracts us from practical solutions that we could do to control healthcare costs. And I do believe that aggressive moves to expand health coverage would be destabilizing. You have to think about what would happen if I no longer have my own health insurance plan and I'm going to be subject to the health plan that everyone else has. And by the way, in terms of those Medicare reimbursement rates, so again, my personal situation. I'm sitting there and thinking, what happens to MD Anderson if they are suddenly being told that they are going to receive the same reimbursement rate as the community hospital somewhere around whose care is just not as good? Look, the care is there. There probably is waste in the MD Anderson system, but a lot of reason why MD Anderson and Methodist, these other places charge more is because it's higher quality care. And what do you do when you don't reward those hospitals for performing higher quality care? We can get in that discussion because it's really hard to come up. We've got some pay for performance and pay for value in our system, but it's really hard to get those proposals right. And then just many hospitals and physicians could not survive if they were paid Medicare rates for treating all patients. So with that, I'd like to open it up for questions. And we've got two people, Brenda and Mara have mics, so feel free.
All right. Professor Ho, good talk. Thank you, very informative as always. A comment and then a follow-on question to that. My first comment is, I enjoyed the talk, but I think you're maybe being a little bit hard on the Democrats here because there are 22 people who have just jumped in the campaign. We got, another 6 to 8 months before a vote's even cast. And if you look back at 2008, we really didn't have firm plans coming together, first Edwards and then Clinton and then Obama, until probably like 3 or 4 months before the campaign. So perhaps maybe a little bit of a wait and see might be let them sort themselves out of it might be a little bit more fair. Now, having said that, there is another stream of Democratic proposals that you haven't talked about before in this talk, and those are basically pothole filling and expansion plans for the current structure of the Affordable Care Act. And there are two that I have in mind in particular. One Elizabeth Warren introduced last year, and another one Frank Pallone introduced in the House. And it's sort of expanding the subsidy ratios, doing some stuff with out-of-pocket costs, more cost control and things like that, closing the family gap and things like that. I was wondering if you could talk maybe a little bit more about that stream of plans, because that's out there as well.
Right, thanks. Yeah, and I recognize that it is early in the campaign. You're right about that. I just want to sort of try and get people's attention focused on what are the things that are feasible, because I don't want to waste my time on things that we're just never going to be able to get implemented. And you're absolutely right, there are plenty of things that have been proposed to, as you said, fill the potholes and deal with the problem we have. In general, what I feel, though, what I'm worried about is there are still many proposals that say we don't have enough people covered in the marketplace, so we've got to do things like expand the income eligibility. So now it's 400% of the federal poverty level, so move it up higher, give people more money. I've written about this before Obamacare got passed. I'm in favor of the legislation, but I also think there's a heck of a lot more that we should be doing in terms of fixing problems that are broken in terms of why are physicians and hospitals allowed to charge such high prices. Because all you're doing when you're giving people more money to buy health insurance is you're giving them a license to spend more money on these same providers. So in terms of the issues, let's focus on hospital consolidation. Let's focus on physician practice consolidation. Let's focus on the cases where health insurance companies have too much market power. And let's focus on drug companies. Let's deal with those things before we start saying, let's just give people more health insurance so they can spend more in our already overpriced healthcare system. But you're absolutely right. I've been told by one expert that I trust, he thinks if the Democrats get elected, they won't change the Affordable Care Act much except try and repair everything that was undone during the Trump administration, but some of them are trigger shy and they don't want to go too far away from that.
Hi, first of all, I want to send you prayers for healing on what's going on. This may be a little bit off topic, but MD Anderson is not currently participating in HMO networks. Memorial Hermann, very few HMO networks. Methodist, the same thing. So if you're saying hospital like MD Anderson, who give a high quality of care, are not going to participate in receiving Medicare kind of reimbursement, but they're not participating in HMOs already. How do we get hospitals to participate in networks like HMOs where the only option for individuals in the state of Texas are HMO programs? Because right now they can't access MD Anderson, who gets a lot of grant money to research cancer to help everyone.
Right.
And aren't we already importing generic prescription drugs from overseas?
I don't believe we are.
Are we already doing that?
I don't believe we are.
So you're saying all generic medications made in the United States?
Oh, I see.
So it's already made overseas?
Yeah, there are some, yeah, of course, Teva Pharmaceuticals, and there will be some. But we pay a U.S. price. We're not paying the price, say, for example, that someone from France, they negotiate a price and they say, all of our medications, this is how much they cost. Ours, it's individual insurers going over there and bargaining, and they're much smaller. They have much less market power, and so they have to pay a much higher price, as opposed to the government going in and just one big, okay, this is America, we're coming and this is how much we're going to pay.
So I am curious on your take on MD Anderson as well as other hospital networks, who I feel sometimes have a little more power than just the insurance company.
Right. So yeah, that's a very tough question, and you can say, boy, lucky enough for you, Rice had the negotiating power, and through our insurer, I was able to go there. And you're absolutely right; they are not covered in the marketplace. They could not reach an agreement. The prices that they charge for their services are higher than many other places. And they do that because they say, look, in order to offer the highest possible, they're the #1 cancer center in the country. And in order to deliver that level of care, they have to charge higher prices. And I saw it for myself because, you know, you could see in terms of, look, I had 3 of the very best surgeons, but backing them up, physician assistants, nurses, you named it, if they needed it right away, they got it. And that's very expensive. So what you're pushing at, unfortunately, is a larger issue beyond just healthcare in terms of the income distribution, the widening income distribution we have in this country, which I'm also very unsatisfied with, but you have a situation, like it or not, where there is this pocket of people, and of course employers, who have the money to be able to pay for this level of health care, and other people don't. Now, there's probably some waste in the MD Anderson system and probably some waste in Methodist, but even if you got rid of all that waste, which is almost impossible to do, you wouldn't be able to lower their prices. And then you have this issue of what do we do when everybody doesn't have access to the same level of quality care. I wouldn't hold the research money against them because that just pays for that research. You know, and the research actually occurs at a loss, and they use some of the income that they receive from private insurers to pay for that research instead. So I agree. You know, ideally it would be wonderful if we could get the MD Anderson access to everybody in the market. The things that I want to push for in terms of higher quality is more competition amongst hospitals and more competition amongst doctors. And it's unfortunate, I agree with you, it's unfortunate we can't all have access to MD Anderson care.
Just a question on healthcare costs that I think you touched on briefly. The U.S. on a per capita basis pays twice as much and doesn't get the same kind of return on outcomes. Could you talk about what do we need to do to get at least to halfway to that level where we can pay less and get more?
Yeah. Okay. So I mean, this has to do with, this is why we can't just sort of magically shift to Medicare-For-All and, you know, lower all these rates. The problem is we've let it gradually march up and up every single year. And then you don't go in and tell all your physicians, okay, we're cutting your salary by 30% next year and you're just going to have to live with it. Okay, but that is what is driving those higher costs in the US relative to other countries. The best we can hope for is slowing the growth. You saw it's still 4%. If we could get it to grow slower than GDP or at GDP for several years, we'd be in much better shape. We actually started in 2000. We actually were doing that for a while when we first introduced HMOs. But the things that the public is not seeing is the massive amount of market concentration, and I think that is what is driving up a lot of the healthcare costs and allowing providers to charge so much money, because there are no more competitors. The other thing I've realized slowly over the last few years is that employers, for some reason, are not, well, they're just not good shoppers for healthcare. It's almost as if CEOs are sort of, oh, I don't understand healthcare. I'm just going to let the human resource group handle that. And as long as my employees are happy, and I'm going to compensate them either in healthcare or wages. And if they want more healthcare, just let them have it, and I'll just increase their wages at a slower rate. So we put up with it because it's all invisible. It's taken out of our paycheck, and we don't see it. It's sort of, you sign up for something, one time in the year, and then they invisibly take money out of your paycheck, and you don't realize what you're giving up. So I'm actually, once I get back up to, full working power, I'm going to be working with employers to try and figure out how they can shop better. Because if hospitals are going to consolidate, providers are going to consolidate, there's people in this audience who know exactly what I'm talking about how large some of these practices, anesthesiologist is one of them, and they're getting very high prices. That's what we have to go after, and it's hard to explain to the public, but I think that's a lot of our problem. Sue.
So, Vivian, one of the issues that keeps coming up as we're having this discussion in my mind is the difference between academic medical centers, where there is research and teaching going on, and arguably higher quality and higher costs, because as you described, just being involved in research doesn't mean you get money and everything's okay. It's really our expenditures at that hospital system institution that actually helps fund the research engine as opposed to the opposite, versus the issue that you just mentioned, which are investments by equity companies and others in healthcare, where the ultimate funding is to drive dollars back into investors' pockets. So, which are now occurring in areas like anesthesiology and dermatology and other areas, and it may be invisible to the consumer. So how do we carve sort of this discussion into the concept of for-profit medicine, which may be fine, and how that may be driving prices up, and nonprofit academic medicine in the discussion of what you're talking about today?
Yeah, excellent question. You and I, we had lunch just last week, but clearly we need to have lunch more. Susan Harris is a health lawyer, one of the top one, has been voted, top health lawyer in, I forget where, Texas and things like that. But you raise a couple of really interesting points. First of all, I've started working with Dr. Anais Offadel, who's actually at MD Anderson, and we just launched a study. We're going to look at hospitals acquired by private equity groups and see if their costs and outcomes are different from other hospitals. So, question yet still to be answered. But the second one is, the problem is, I don't think the FTC and Department of Justice have in their toolbox the ability to undo these mergers right now. I mean, the thing is whenever one of these comes up in the press and they want to announce another merger, I can comment, and I've gotten in trouble for that, but I do continue to comment that these are bad, all right, and that they raise prices, but that doesn't do anything to the ones that are already there. I think it would be interesting to, and I'd like your perspective on that as a health lawyer. Can we change the legislation to say, look, Herfindahl market concentration above 40% is unacceptable, and we need to unwind some of these, okay? So it's kind of like, if you remember back then when we unwound AT&T, or, sort of doing something to the airlines, and that's very drastic, and it's hard to do, but that may be where we have to go in order to slow down some of these healthcare price increases.
Thanks for a wonderful presentation, but in your beginning slides, one of the numbers you ought to put up on your slide is how much are corporations actually paying for healthcare today? Because that is an important number, and it's one of the most important numbers, and I thought you did address it when you talked about the 7.5%, which actually seems to be probably reasonable, but...
yeah, indirectly, yeah.
So that's one thing. Another thing, though, there are a couple studies that could be done. I don't know where you get the resource to do all this, but for one thing, you talked about 20 different procedures that are in that table you showed. Mm-hmm. If you looked at the cost of those 20 different procedures across 10 or 15 major hospitals around the United States, what would we find out about the way these costs are between hospitals, and who is the least expensive and who is the most expensive?
So yeah, that's a good question. There's a gentleman, Chapin White at Rand, who's actually done a survey like that. And Sue, you shared the numbers. I can't remember if does it have individual hospital names in it? So you could actually, sometimes you can see this is hospital A and hospital B. You might have access. So it's not clear that you can get that for every single hospital, but that number's starting to come out, and that's one of the things that employers need to fight on. They say, look, you've done this MRI for this, and we're paying twice the amount that the other hospital is, and they're pretty good too. Why are you doing this?
We talk about the high, all these costs, the reductions, and that would have to, for the providers to have to take for these different plans. But could you do a study that would show what the cost structure is of major hospitals in different countries and what their physicians are being paid in major countries to see how significant these differences really are?
Okay, so there have been New York Times articles that have come out, and physicians in other countries get paid half as much as they do here, or even much less than half. Those numbers are out there. It's very hard to get the hospital costs. Strangely enough, once you move to something like global budgeting, where they just say, here, you get $100 million, make that last the whole year, they don't do cost accounting like we do. And so it's actually harder to get some of that cost information from those other countries than it is here. So that's unfortunate. Well, let's take one more question. Yeah.
So I was just hoping if you could talk a little bit more. So we were talking about specialty care and costs and comparing Medicare costs versus other costs. I was hoping if you could talk about how the whole pie of U.S. healthcare costs are divided in terms of primary care, specialty care, and in making kind of the specifics about Medicare costs versus private payment.
Oh, how does that feed into it? Yeah. There was a survey that came out just this week talking about the 5 highest paid specialties. There's no doubt it's unevenly distributed. If you're in primary care, you get the short end of the stick, and internists. And then the more specialized you are, the better. And so I think up on the top of there, ophthalmology, some types of specialized medicine and things like that. So that's the other problem I have. In terms of when you saw the numbers, there are lots of physicians that make $600,000 a year or more, okay? And to me, I sit there and see $600,000 a year or more. I bet a lot of you would say, hey, I'd be willing to train to do that job too, right? And I also think a lot of the people in this room are intelligent enough to do that job. But physicians control the number of people who are allowed to train to do these jobs. And that's another thing we could think in terms of a massive movement that is not about increasing expenditure on health insurance. Let's change the way in which we allow the number of people to train for these particular positions. Because, I would even say, look, you don't have to be a rocket scientist in order to do some of these. And we could have more people, more supply, and lower down the rates. And that would help in terms of the salaries. Okay, I want to thank you again. You have terrific questions, and they're all over the board. And if you don't like what I said, feel free to email me and complain about me. We will send you a SurveyMonkey form, and we send this out every year, but we don't get enough responses. So please fill this out, because if we get, we usually only get about 20 responses, and if we get 20 responses, we can't tell, we'll ask things like, what would you like to hear about? And if we only get 1 or 2 responses, we can't really tell. We're not going to change, the entire program based on that. So please do take some time and think about what you'd like to hear from us next. Thank you so much. Thank you to Brenda for organizing these events, and our audiovisual and events people. You've been terrific every single time. And I look forward to seeing you at another one of our events in the future over the year. Thanks.